All right, we're going to go over the urinary and reproductive system, same kind of way that we have been. What is the function of the glomerulus? Reabsorption, secretion, or filtration? Remember, the function of the glomerulus is filtration, so it's pushing everything out from the blood except for blood cells and proteins. Everything else is being pushed into the glomerular capsule so that it can be sorted through. So everything but cells and proteins. What is the functional unit of the kidney? Nephron, collecting duct, glomerulus only, nephron loop only. That is the nephron. So the functional unit, so what is making urine in the kidney is each nephron. They work together with the glomerulus and the proximal convoluted tubule, the nephron loop, the distal convoluted tubule, all part of the nephron, and all of it is making urine all together. Where does most of the reabsorption occur? Glomerulus, distal convoluted tubule, proximal convoluted tubule, the nephron loop. That's the proximal convoluted tubule. Now remember, we push everything out with the glomerulus. It's filtration. Push all of the everything but proteins and cells into um, the glomerular capsule, into the proximal convoluted tubule, and then we reabsorb most of it immediately. We don't want to get rid of glucose. We absorb most of the water. We absorb everything, reabsorb. So we have pushed it out and then we take it back in. So again, it's like dumping out a box of things that you don't know what's inside and then immediately putting most of it back in the box. And then you kind of use the rest of it of what you want to get rid of. Glomerular hydrostatic pressure minus capsular hydrostatic pressure plus blood colloid osmotic pressure is what term? So this is overall. Think about kind of everything. Is it the glomerular filtration rate, net filtration, glomerular hydrostatic pressure, or capsular hydrostatic pressure? This is looking at net filtration. So remember, and switch. Looking at here, remember when you have the glomerular capillaries coming in, and then you have the capsule around it. The glomerular hydrostatic pressure is basically the blood pressure in the glomerular capillary. So that's pushing everything out. So that is going to be mainly your filtration kind of rate. Then whatever fluid is filling the capsular space is going to put a pressure back on the wall of the capillary, and that is your capsular hydrostatic pressure. Plus, there's still proteins that are staying inside the capillaries and cells. And that, remember, colloid osmotic pressure is water wants to stay where the proteins are. The more solutes, the more large solutes are still inside. So the water wants to go back into there. And that's the colloid osmotic pressure. So we're looking at overall which way is the pressure going. The net filtration pressure is going to go out. Um, if it's normal, because the hydrostatic pressure and the blood colloid osmotic pressure is less than the glomerular hydrostatic pressure. Your blood pressure suddenly increased. What will your kidney immediately do to respond? That is going to constrict the afferent glomerular arteriole. So this is, remember, is autoregulation. If we look, again, if remember, we have the afferent arterioles coming in, makes the glomerulus, and then we have the efferent, which is exiting. If all of a sudden your blood pressure outside in your peripheral circulation goes up, that is going to cause blood flow to increase, to be a lot more blood flowing because of the pressure increase. So what the kidney is going to want to do is, instead of being large and normal, it's going to constrict down the afferent, so that even though the blood pressure hasn't had an effect on anything with blood pressure in the rest of the body, but it's controlling flow into the glomerulus. Having a smaller hole, having a smaller diameter means there's less blood that can flow in. So the glomerulus is maintaining its glomerular filtration rate to a specific amount. So pretty much it's going to maintain the glomerular hydrostatic pressure to a steady amount, because we want to steadily make urine. We don't want to be overwhelmed. We don't want to miss things if your blood pressure is continuously high. Um, so the immediate, when blood pressure increases, the kidney's first going to constrict the efferent arteriole. Opposite's true if all of a sudden your blood pressure is decreased for whatever reason. We want to maintain that blood flow. So same thing, you have less blood flow going into the glomerulus. So you're going to dilate the afferent arteriole so you can maintain blood flow. There's lower pressure, but you can increase the space to make sure that you're maintaining the blood flow into the glomerulus. Here. If your blood pressure is constantly low, how will your kidneys respond? Release renin, constrict afferent glomerular arteriole, release ADH, dilate afferent glomerular arteriole. So we just talked about dilating the afferent glomerular arteriole if your blood pressure is low, but that's if it suddenly becomes low. If it's consistently low, where you have chronic low blood pressure, that's when your kidneys are going to release renin. And remember, renin and then is converted to angiotensin 1 and 2, and then release aldosterone. And then aldosterone is going to increase your sodium reabsorption. And then remember, wherever sodium goes, water will follow. So by maintaining your water and urinating out less water, you're keeping more fluid in your vessels. And so therefore, you're keeping increased blood pressure in your vessels. True or false, the ascending limb of the nephron loop is permeable to water. Remember, that's false. The ascending limb of the nephron loop is permeable to solutes, specifically going to be sodium, is going to be the major one. The descending limb of the nephron loop is permeable to water. So only water is moving in the descending limb of the nephron loop. Only solutes are moving in the ascending limb. Facultative water reabsorption occurs in which of the following? Nephron loop, proximal convoluted tubule, glomerulus, collecting ducts. Facultative water reabsorption means it comes and goes. So if it's needed, like ADH, antidiuretic hormone, is going to be around, then it's going to have effect on the distal convoluted tubule and the collecting ducts. So out of those options, be collecting ducts. Obligatory water resorption is happening in the proximal convoluted tubule and the nephron loop. Remember, the nephron loop has the countercurrent exchange. So I just talked about the limbs being different permeabilities. So use the solute concentration to pull it out more water. The proximal convoluted tubule has aquaporins in it all the time, so water is immediately reabsorbed, and most of the water reabsorption is happening in the proximal convoluted tubule. Sympathetic nervous system is responsible for the micturition reflex. That's false. Remember, sympathetic nervous system is the fight or flight nervous system. Yes, you may scare some pee out of you, but actually peeing or urinating is parasympathetic nervous system. So when you're resting and digesting and making urine, then you're going to urinate it out with parasympathetic nervous system. Which of the following is a treatment for renal failure, diuretics, dialysis, surgical removal, increased protein intake? Dialysis is going to be the treatment for renal failure. Also, chronic renal failure is going to be kidney transplant if possible. But remember, use dialysis machines to basically act like a kidney so that it can take out waste products and cause reabsorption. So it's basically taking the role of a kidney as a dialysis machine. Now moving on to the reproductive system, which of the following is involved in temperature regulation of the testicle? Myoid cells, testicular artery, inguinal canal, or the Dartos muscle? That's the dartos muscle. Remember, the dartos muscle is in the kind of the skin of the scrotum, so it'll wrinkle and kind of help with temperature regulation of the testicle. The other one is going to be the cremaster muscle that goes down the spermatic cord and pulls the testicle towards the body. The last one would be the piniform plexus. So the veins, remember the venous blood is cooler than the arterial blood that's coming down from the aorta. So the veins can actually absorb blood from the artery to help with temperature regulation of the testicles as well. What's the function of the epididymis? Sperm production, sperm maturation, hormone production connects with the urethra. Remember, the epididymis is where sperm are maturing, meaning they're getting their tail and being able to swim. So spermiogenesis is happening in the epididymis. Sperm production happens in the seminiferous tubules. Hormone production also happens in the cells of the seminiferous tubules, and the ejaculatory duct is what connects with the urethra. Majority of the fluid of semen is produced by what? Seminal glands, prostate glands, bulbourethral glands, seminiferous tubules. Remember, most 70% of semen is produced, the fluid of semen is produced by seminal glands. The rest is the prostate and the bulbourethra. Bulbourethral makes the least amount. The prostate gland is the second, and then seminal glands is the most. So kind of remember which ones are which and what they're producing. What cells undergo mitosis in the seminiferous tubules? Primary spermatocytes, spermatogonia. Secondary spermatocytes, spermatids. Remember, these are spermatogonia. So back to my presentation. Remember, we have spermatogonia, which are the actual stem cells. So you have spermatogonia. They divide into maintaining spermatogonia and going into a primary spermatocyte. The primary spermatocyte goes under mitosis, or no, meiosis. You have mitosis here. Meiosis 1, and you get 2 secondary spermatocytes. Those both undergo meiosis 2, and finally you get spermatids. And you get 4 of those. The spermatids undergo spermiogenesis to actually form sperm. And gave the answer to this one already, but so just mentioned it, meiosis 1. So the primary spermatocyte is developed from mitosis of the spermatogonia. Primary spermatocytes undergo meiosis 1 to produce secondary spermatocytes. Secondary spermatocytes undergo meiosis 2 and then become spermatids, which then do spermiogenesis to become sperm. Kind of just gave this answer away too, but what is the term when spermatids are changing into sperm? Spermatogenesis, spermatodosis, spermiogenesis, sperm activation. Spermiogenesis is spermatids changing into motile sperm. So spermatids basically have all the components to make into sperm and to have the nucleus with the proper amount of chromosomes, but it needs to change into actual motile sperm. Which cell is essential to spermiogenesis? These are nurse cells. So remember, nurse cells are making the blood testes barrier. They're also providing nutrition, helping move spermatids along, eventually going to spermiogenesis. The interstitial endocrine cells are what are making testosterone, which are important in making sperm, but the nurse cells have a major role in making sperm. FSH causes what to occur in males? So FSH in males is for sperm production. And remember, inhibin is released and inhibits FSH, so you can stop or slow it down. And then LH is having effect on the interstitial endocrine cells that have testosterone production. Remember, in females, FSH is follicle stimulating hormone, so it's stimulating follicular development in the ovaries. And LH, especially the LH surge, is what causes ovulation. What extends from the ovary to the lateral pelvic wall? That's the suspensory ligament. If you're looking again at kind of ovary, uterine tube, or fallopian tube down to the uterus, thing, the suspensory ligament is coming off and suspending to the lateral pelvic wall. The ovarian ligament is suspending between the uterus and the ovaries. The broad ligament is kind of all the large kind of section surrounding the uterus. And then remember, the mesovarium is just kind of this section between the ovarian ligament and the uterine tube or the fallopian tube. Remember, the amount of oocytes that a female has is done at birth. All the mitosis that's occurring in females occurs in the fetal development, and the supply that a female has is completed when they're born. Remember, the secondary oocyte that is stopped or arrested in metaphase 2 is ovulated. So then once if fertilization occurs, then the finishing of meiosis 2 will be completed. Primary oocytes are suspended or arrested in prophase 1, and only the ones that are going to get into mature mature oocytes are going to go into the meiosis 2 and stop in metaphase 2. After ovulation, what is formed in the ovary, so what happens to that follicle, the tertiary follicle after the secondary oocyte is ovulated, that becomes the corpus luteum. So the corpus luteum, remember, a lot is producing estrogen, but a lot of progesterone to help maintain that uterine wall. If there's no fertilization and no stimulus to continue, the corpus luteum will stay around if it is. If there is no fertilization, so if there is fertilization, the corpus luteum will stay around. If there isn't, then it becomes the corpus luteum, then the corpus albicans, the scar. What part of the endometrium is lost during menses? That's the functional layer. So that's where the glands are going to be enlarged. That's where everything is going to be ready for implantation if that does occur. If it doesn't, then it's lost during menses and then it's rebuilt again by the basal layer. Remember the phases of the uterine cycle? So you have menses, which is the menstrual period, where the functional layer of the endometrium is lost. Then you have the proliferative layer where it's regrowing, so that functional layer is being regrown and regenerated. And then the secretory layer is when the uterine, or secretory phase is when the uterine glands are enlarging, they're getting ready for implantation. Estrogen levels are highest during the ovarian phase of the follicular phase and corresponds with the proliferative uterine phases. So remember, those kind of graphs. So estrogen is going to be increased. The follicles are going to be producing it. So this is where the follicles are being produced in the ovaries, and progesterone levels aren't that high. Then, so the proliferative phase in the uterus, so the uterus is regenerating. Then, when LH is stimulated, the LH surge is produced, then that's when ovulation occurs. And at ovulation, you go from the proliferative to the secretory phase. If nothing happens with fertilization, then you go into the menstrual. And secretory phase goes into the luteal phase of the ovaries, because that's when the corpus luteum, and that's when progesterone takes off. Estrogen's still around, but just not at highest levels. Uh, so I hope that helped. If you have any questions, just email me. If not, good luck on the exam.